So VT Reach stands for Virtual Teleconference, Reach, Explore, and Aspire to Careers in Healthcare. And today we are spotlighting nurse practitioners.
Yes, and so with us we have Erin Berg and Maria Cochrane, and we're so excited to hear about their journeys into medicine. While they're speaking, if anyone has any questions, please put them in the chat and we will address all the questions during a Q&A session. And so as they come up, you can type them right in the chat. And we'll begin with Erin.
Hi, I'm Erin. I'm a nurse practitioner. As you see on the screen, it says ANP BC. All that means is that I'm a board certified adult nurse practitioner. And then the MSN means I have a master's of science in nursing. And probably get into that a little bit more as it goes on. Right now I work at the University of Vermont Medical Center in the Transplant and Hepatobiliary Surgery Service.
And Erin, what is your inspiration into medicine?
Oh yes, sorry. So my first job out of college was working at the Dana-Farber Cancer Institute as an administrative assistant. I scheduled appointments and did administrative tasks. As I'll talk about in my education slide, I went to school for political science, which I have a bachelor's degree in, but I didn't really know what I wanted to do. So I loved working at Dana-Farber. I had an awesome team that I worked with, and the nurses and nurse practitioners really inspired me and took me under their wing and encouraged me to become a healthcare professional. And I decided to become a nurse practitioner because of them, and I'm eternally grateful for them. So when I decided on that path, like I said, I went to St. Michael's College in Burlington or Colchester, Vermont, and I got a bachelor's degree in political science. So when I decided that I wanted to become a nurse practitioner, I had to do prerequisites. So it's basically like a biology degree that you have to get. So I went to a community college because I was working full time. And I did all the prerequisites. It took about a year of going very part-time while I was working full-time. And then I did a direct entry nurse practitioner program. Direct entry programs are for people who already have an undergrad degree. So you've done a lot of, I hate to call it, but like the fluff courses. So if you have a bachelor's degree in something else, you do your prerequisites, you can do a direct entry program. So I became a registered nurse and then a nurse practitioner within a 3-year time span. And I went to the MGH Institute of Health Professions, which is all direct entry healthcare programs, and that's in Charlestown, Massachusetts. So when I went to that program, the first year and a half was RN. So we did clinicals like on mostly inpatient on medical surgical floors and kind of learned the basics. After about a year and a half, we sat for our NCLEX, which are the national nursing license boards that everyone who wants to be a nurse has to sit for and pass. And then once that was passed, we started the nurse practitioner portion of our program. So those were more advanced studies, and we started clinicals. Most of my clinicals, it depended on what you were going, which track you were in. Like I said, I'm a board certified adult nurse practitioner, but I actually went to NP school as an adult nurse practitioner and a women's health nurse practitioner. So I did clinics kind of all over. I did a clinical at a Lyme disease clinic. I did one at Planned Parenthood, inpatient, outpatient OB/GYN. So that was more OB, and then seeing patients on the labor and delivery floor. and then also a couple of primary care offices. So you basically go around with the nurse practitioner, or sometimes it's a doctor, and they kind of guide you through and show you, what a day in the life is, and teach you how to take care of patients in various settings. So then once you fulfill enough clinical hours, and there's different requirements depending on what boards you're sitting for. When we graduated our program, we did get a master's degree and a bachelor's degree. And then you have to sit for the nurse practitioner boards under your specialty. And there's 2 different agencies. Maria may have a different experience with this. My understanding is that there's not much difference, except if you need to take a specific board, maybe one has it and the other doesn't. I did ANCC, and then once you become board certified, you can apply for state licenses. To hold an NP license in any state, you also have to hold an RN license. So you have to apply for the RN license, and then once you're granted that, then you can apply for the NP license, or sometimes they let you do it together. So the responsibilities of a nurse practitioner are different depending on what setting you work in. Like I said, I work for transplant and hepatobiliary surgery. So I work both inpatient, so patients who are admitted to the hospital, whether that's for a medical issue or post-surgery or post-transplant. I do pre and post-op evaluations, inpatient and outpatient. You order and interpret tests, so that's like lab work, imaging, like CT scans or MRIs, X-rays. I'm trained to assist in surgeries if needed. You also work on research, if you have time or if that's of interest to you. I do things like fill out disability paperwork and FMLA paperwork for people if they need time away from their employment because of their illness. I participate in multidisciplinary tumor boards and multidisciplinary meetings, especially being on a transplant team. We help precept NP and PA students to get their clinical hours. We also work with residents, so we, kind of help in a sense to precept them as well. Inpatient, I round daily with the attendings and the residents on my service to see the patients. We split tasks of reviewing and managing orders, and I do a lot of education for all our patients, but specifically for transplant patients, because there's a lot to learn when you're post-transplant. And one of the big parts of my job is doing discharge planning, which can be very complicated. Sending people home on tube feeds, IV antibiotics, or just trying to get them home health or other social services they might need. And then outpatient, I do clinic. I only do clinic once a week because of my inpatient responsibilities, and I do a lot of oncology surveillance follow-up from patients we've done surgery on, follow-up appointments for people who have been in the hospital, maybe they need long-term care. And then I also do transplant new referral phone screenings. And then you spend a lot of your day kind of triaging phone calls that come in, or kind of just doing all the less glamorous parts of the job, ordering medications, following up on tests, things like that. So my work schedule right now is Monday through Friday, about 8 to 5. I mean, I don't think that as a healthcare provider, you really can always say that you work set hours, but in general, I luckily don't have to work on the weekends. And I generally have, pretty good hours. I think sometimes it's always hard to find a work-life balance, especially if you decide to go into healthcare and you feel dedicated to your career and your patients. I like to tell these facts because I think it's helpful for people when they're looking for jobs in healthcare. So most nurse practitioners are salaried, which means you kind of are expected to work X amount of hours, but you're not paid by the hour. You're paid like essentially a yearly salary. And as long as you get your work done, you get a little bit more flexibility in your time, because some days you're working nonstop. You don't get to eat lunch. You don't get to go to the bathroom. You're working, 15+ hour days. And then other days things are slower, and, maybe you can come in a little later or leave a little earlier, knowing that it all balances out. I don't do any call for this particular job that I have now. And I don't work weekends. So I like that, because it lets me do things that I enjoy and spend time with my friends and family, which I think gives me, I would say, in general, a decent work-life balance that I feel pretty grateful for.
Okay, thank you so much, Erin. And next we are going to hear from Maria and her inspiration into medicine as well.
So I'm Maria Cochrane. I know Erin sort of went over some of this stuff a little bit, but the letters after my name mean that I am an adult gerontologic nurse practitioner. That used to be two separate certifications, meaning adults, and then gerontology is elderly people, so geriatric medicine. This became a combined board option when I was in graduate school. So now it's a single certification that I sat for. I also have my master's in nursing, which is the MSN, and my master's in public health. My inspiration into medicine is multifactorial. Unfortunately, as a young woman, my family experienced some significant trauma, and we were heavily involved with a level 1 trauma center and subsequent care for several of my family members for quite a while after that. The nurses and the nurse practitioners in particular were just really life-changing people. And so for me, that sort of started the wheels turning. I always thought I wanted to go into medicine. I wasn't sure what that meant as a young person. But as we click forward here, we can kind of see. So I went to UVM, the University of Vermont, in undergrad. I got my bachelor's in economics and chemistry. I fulfilled all the pre-med requirements at that point, but at graduation, I wasn't sure if medical school was where I wanted to go. So my first job out of college was working for an infertility clinic, and I was the liaison between that clinic and the specialty pharmacy that provided all the medications for specifically donors, egg donors, and surrogates. And so I, kind of, again, was exposed to patient care, and the nurses were, providing all the patient education and coordinating all the procedures and things like that alongside me. I became really interested in research during that period of time, and ultimately left that position to pursue my master's in public health, which then led me into internships with the CDC, the main CDC, initially in infectious disease epidemiology. And to make a long story short, I was a research assistant in tuberculosis control, and worked very closely with the public health nurses and some refugee populations in Portland, Maine. And those men and women inspired me tremendously. And so I thought, maybe nursing is the way to go. And then I encountered an NP who was also working kind of in that realm. And to me, becoming a nurse practitioner really felt like the marriage of medicine and nursing that to me sounded like, the right fit for me. So like Erin, I went into a direct entry program. I returned to Burlington and the University of Vermont for that. The structure of my program was very similar to what Erin described, so we can sort of move through that. But we can go to the next. So as I said, very similar, parallel to what Erin was talking about. The first 18 months are of the direct entry programs are intensive RN training and rotations. Once we completed that portion of our education, we had to sit for our NCLEX and then, get our subsequent state licensure in order to continue. So then the graduate portion of our program for NP school, again, kind of tailored to which specialties you're going into. For me, I spent a lot of time doing elective surgery rotations. Surgery was not actually a part of the program I was in for adult gerontologic NPs, but it was something that really interested me. So I did, in addition to, the elective opportunities through my program, I also did some additional time in surgery with the hopes of ending up in a career in surgery long term. But as you can see, kind of broad strokes. So primary care, endocrinology, cardiology, primary care being kind of the meat and potatoes, primary care and internal medicine. So inpatient and outpatient. And then again, sitting for your boards and getting your state licensure to enable you to secure a job. So I initially, out of school, worked for a general surgery service. I have since moved to what is called acute care surgery. So what that means is basically emergency general surgery. So anything that you come in through the emergency department, the most common things being things like appendicitis or cholecystitis, meaning your gallbladder is infected, things like that, and trauma surgery. So now that's sort of my role. And we'll talk a little bit in the case study about sort of the start to finish and what that looks like. But I am sort of all over the hospital every day. I evaluate patients in the ED, in the emergency department when they come in. I first assist in surgeries, do a lot of bedside procedures and wound care management. Sort of the same sort of structure as any other inpatient service and like Erins service, rounding on patients, evaluating changes in patient status, responding to nursing concerns, responding to trauma alerts. I do, as I said, a lot of the complex wound care, burn care, things like that on the inpatient side. The outpatient portion of my job is really quite minimal. I do some triage, like backup triage for the nurses. So if our nurse is, concerned about something or wants somebody to take a look at something, that person is often me. We do accept some limited wound consultations in the outpatient setting, and we see our postoperative patients and follow up. Like Erin, I work in an academic medical center, so working with medical students, PA students, NP students, and residents is, a big part of our day-to-day. And then collaborating across disciplines, whether that's physical and occupational therapy, speech and language therapy, other surgical services or medicine services. So it's a pretty broad net that, my duties fall into. So my schedule is a little bit different. In acute care surgery, depending on where you work, a lot of providers work 12-hour days. We are, by definition, as the emergency surgery service, in-house 24 hours a day. Thankfully, in our institution, the NPs and PAs are not in-house 24 hours a day, but that's not the case everywhere. But I work 3 12-hour days. Occasionally, I work a 4th day, depending on the week and the wild schedule. And then I rotate weekends. So, there are pluses and minuses to that for sure. But I have a young son, and having some weekdays off with him has been really lovely. When I'm not at work, I, as you can see there, like to do all kinds of different things. But I, as Erin mentioned, think that being able to find the balance of doing the things you care about and being with the people you care about really better serves both you and your patients.
Thank you both. And so I'm going to bring you both on the screen. And I just have a question to start. I was hoping you could explain really the main differences and similarities between a nurse practitioner, a physician's assistant, and a physician, and kind of the limitations or like the scopes of each one.
Sure. So some of that, to just put a disclaimer out there, some of that depends on the state you live in. Nurse practitioners have independent practice in many states. I don't know the final tally, but the last I knew, I think it was 22 states. Physicians assistants don't have that yet. And in fact, they are changing their verbiage. They're going to be called physician associates. And I believe that they are actually also pursuing independent practice, but at present, their practice is linked to under a physician's license, a supervising physician. So in the state of Vermont, we do have independent practice, but in the facility or in the institution we work in, so Erin and I both work for UVM Medical Center, we have to have a collaborative agreement with a physician. So it's a super complex and nuanced question. I would say though, in practice, the big things that are different are NPs are becoming more and more specialized, whereas PAs are, there's one certification that they can get, one board that they sit for, whereas we have, diversified. So there's adult nurse practitioners, acute care nurse practitioners, pediatric nurse practitioners, women's health, et cetera. The physicians, there's MDs and DOs and nuances there too. But they are all independent providers. And they go through residency. So that's years of training after medical school to become board certified in whatever specialty they elect to pursue. NPs and PAs can do residencies, but we aren't locked into a specialty in quite the same way. So, tonight you're talking to two NPs who work in surgery, but NPs work all over the place. And, Erin and I could conceivably work in a different specialty someday if that's something that we wanted to do. And Erin, I'm sure you have a lot to add to that too.
Yeah, I think that, you gave a much better explanation than I could. I think that the schooling length for PAs and NPs is probably similar, but I do think that PAs kind of have a much more broad-based education. They do surgical rotations. That's just part of their program. Whereas like Maria said, she, kind of had to find those for herself. I had no surgical clinicals or experience really during my NP clinicals. But a good example of how NPs can kind of move to different practices is my first job out of NP school. I was actually a GYN oncology nurse practitioner. So as an adult nurse practitioner, board certified, which is why I only sat for that board rather than also doing the women's health one. You can practice on anyone. I think it's like age 12 or 13 until death. And so because I had women's health experience with clinicals and I was passionate about that, I did normal GYN exams. Like if you, have a uterus and you need to see a provider and get that type of care, pap smears, things like that. And then I learned how to do surgery there because we did oncology services. And like I even learned how to do chemotherapy there. And then when I left that, I moved to a completely different service. Kind of the link was that they both did surgical oncology to some extent. So I do think that you can really kind of pin yourself into a specialty with nurse practitioners. Like you have to know you want to be a pediatric nurse practitioner if you're going to go to school for that and sit for those boards. But if you do something like adult geriatric or family medicine, or family health, which a lot of nurse practitioners do, or adult health, I think, you really can expand your career based on your interests.
Okay, thank you so much. That was definitely very informative. And I know that there's definitely that's where things can get a little muddled with the terms of scopes of practice with all those varying degrees and things like that. There is a question from the chat from Claire, and I believe it is for Erin, asking what made you decide not to go into women's health, which I believe you started to pursue. And if you have any tips, this could be for both of you as well. If you have any tips for aspiring women's health NPs.
Yes, so I actually went to nurse practitioner school to be a nurse midwife. And unfortunately, they shut the program down while I was there. So the best way to pursue that is everyone that was in that program, we kind of moved to women's health. But I think almost all of us got dual women's health and adult health. We fulfilled the clinical requirements for both of those. Again, so that we weren't kind of pigeonholed into one thing. Like if you do women's health and that's it, then that's really what you need to practice in. This isn't a great answer because it doesn't really sound great. Women's health is my passion and what I want to do. And actually my first job that I had, which was the GYN oncology job, it was everything that I wanted to do and why I became a nurse practitioner. Unfortunately, sometimes you really need a job and are excited when you're a new nurse practitioner, and maybe the first place you practice is not your forever home. And living in Vermont, there's not always a lot of opportunities. And I also had a non-compete clause in my contract. So when I left that job, I was still interested in surgery. And when the job I have now came up, I, went for it. And, I feel really grateful to have learned so much in this position. But it's no secret even to my colleagues I work with that I hope to, move on to at some point to go back to women's health. But I would really caution anyone who wants to become a women's health nurse practitioner to not only do the women's health certification, to really do a dual adult women's health, or just do adult health if a program doesn't offer women's health specifically, and just try and get clinical experience in women's health clinics, OBGYN, infertility, things like that.
Thank you. We have another question from the chat from Eva, and she asked, would you recommend taking a gap year off post your undergrad? If so, what would you recommend doing, and what do you wish you would have done?
I guess Maria and I both can answer something good with this because we pursued different careers and went to college for something else first. Do you want to talk about that, Maria?
I would definitely recommend, whether or not you formally take a year off, I would definitely recommend working in some capacity with patients before you commit to a career like this, because it's not for everybody. And I think that the experience you get is invaluable. I worked, just by doing a direct entry program, I worked as a nurse while I was in NP school. And that experience, more in human interaction than almost anything else, was something that was tremendously beneficial for me. So if you're able to take a gap year and work, as a medical assistant or do something with patients, that's great. If you can't, then trying to find those experiences along the way, I actually think that's a really, really important thing.
Yeah, I think that I never would have gone into healthcare if I hadn't worked, as I got a job as an administrative assistant because I needed a job. I had graduated college and, I needed a job. And I will be forever grateful to have worked in the capacity of, that job where you really learn the basics, you learn how the systems work, you learn the jobs that everyone does. And to be honest, you're a little bit at the bottom of the proverbial totem pole. And I think it gives you a lot of insight into the workings of healthcare, but it also, as you decide, or if you decide to move on to be a provider or just in healthcare in general, it makes you appreciate everyone's position and how much everyone on a team needs to work together. So, working as a personal care attendant is, I think that's call them PCAs, or a medical assistant, like Maria said, or even honestly at the front desk at a medical office. It's all going to give you good experience and insight, and you'll be able to talk to so many different people in different healthcare careers, and I think see if that's right for you.
Okay, thank you. There's another question kind of just relating to this conversation, asking about getting an LNA and if there is any reason that that's frowned upon as part of a journey to NP.
Absolutely not. That is one of the greatest things you can do. I would never say that that's frowned upon. The LNAs or CNAs, again, depending on where you live, provide, most of the hands-on daily care to the patients, in a less technical way. But you really, as Erin was kind of mentioning with some of the other roles, you see the hierarchy, you see the politics, you see the systems, you see how nurses and providers interact. I think that's tremendously valuable experience. And even things that that people come out of medical school not knowing how to transfer a patient or how to do things that LNAs do every day, that I think are invaluable and that will serve you for your whole career.
Yeah, I 100% agree. I mean, I know from working at the hospital, a handful of people who worked as LNAs, or the PCAs are some of the people who help transfer patients, especially in the OR. They do some of that work too. And then the LNAs on the floor, who a lot of them went on to NP school, med school, and they took those positions because it's a smart decision. You want to have experience and have gotten your hands dirty in that before. I really think it works to your advantage before you kind of just jump into the book learning, and you really know that you want to pursue that career.
Thank you. I have a question about if say someone in high school is really passionate about the idea of being a nurse practitioner, what is the most direct path to get there? I know you both did a little in-between work before deciding to be an NP. If someone knew early on, is there a faster way to get that degree?
I don't think it's faster, but it's definitely more direct. I think the classic route is that you go to get your RN, so a bachelor's in nursing. Maria might be able to clarify. I'm not sure if you can get an associate's degree in nursing and pass the NCLEX and then go on. I know a lot of, unfortunately, a lot of states and facilities and big hospitals have moved away from accepting associate's degrees in nursing, which is a whole other thing. It's ridiculous because we all sit for the same boards. But so you could go to school to get your bachelor's degree in nursing, and then you would go to a master's program. And some programs kind of have like a track you can be on where it's like a 5 or maybe 6-year program where you would go RN and then you're kind of like already enrolled in their master's program to get your NP. And a lot of schools are moving towards not doing masters in nursing anymore. It's actually a doctorate in nursing. So I think that does maybe prolong it a little bit.
Yeah.
What do you think, Maria?
I do think the direct entry programs all require a bachelor's degree. But as you said, I do think there are combination programs where you do your bachelor's, your undergraduate work, and then matriculate directly into a DNP program or a master's program, depending on what that school offers. So that's probably the most direct route.
Okay, thank you. Another question from the chat saying, if you considered doing an MD, do you have any regrets choosing the NP route? Do you ever wish you had more responsibility or that you didn't have to kind of report to a physician?
I definitely do 100% do not wish that I was an MD. I think that one of the reasons, and I don't want to speak for Maria, but I know we've talked about this before. I think Maria and I both feel very passionate about being nurse practitioners and really want people to understand what a nurse practitioner is. And unfortunately, there is some like stigma around the role. It is misunderstood. But I mean, in Vermont, like we could open our own practice and not have to answer to anyone except for our patients. I mean, there are primary care clinics in Vermont that are solely run by nurse practitioners. I have a nurse practitioner who I precepted who opened her own primary care office. So I really like this role. I do not wish that I had spent all my time and resources and money going to med school and doing residency. I like working in a collaborative environment. And I think as a nurse practitioner, we're slightly more holistic and we're taught to kind of treat the whole person, not just their ailments. And I think that is a little bit lost sometimes in the very like rigorous med school to residency track.
Yeah, to echo, certainly I am somebody that really seriously considered medical school. And from where I sit now, I would say that I don't have any regrets about the path that I took. I think, as Erin said, unfortunately, our role is misunderstood. And I think some of that comes from it's really varied depending on where you practice. The fact that we practice in surgery, you can never be an NP that's an independent practitioner in surgery. But that said, I'm responsible for the patients I manage, and I have a tremendous amount of independence in my role. I think if, independence and the title and being the person is really important to you, then medical school, is something that you should really consider. But I think as the world moves forward, the models that we're seeing in the bigger hospitals are, very collaborative. So physicians and NPs or PAs. And the more time I spend in medicine, the more I think that who you are as a provider is a lot more about who you are and what your skill set is than the letters after your name. But I do think that there's tremendous value in having a nursing background and then learning to practice medicine. It's a pretty unique pairing that you don't really see in the other medical practitioner tracks.
Thank you so much to both of you. I think this is a really good and important conversation. We are going to move on to the case study portion of this, but if anyone has more questions, we will be able to address them in our second Q&A. So we're going to let Maria and Erin talk about cases that they see and work on in their roles as nurse practitioners.
So I thought, because Maria and I do have some overlap in our practice, I thought that I would focus more on what it's like to be on the transplant team, and kind of show the intricacies, which hopefully will highlight kind of all the variety of things that as a nurse practitioner you can be involved in and work on, because I think it can translate to a lot of different settings. So I'm just gonna, this is very broad. Transplant is very complicated. So I'm just gonna kind of go through the steps that it takes from when someone's referred until post-transplant, but it is a lot more complicated than this. If you want more information, you can always go to the UNOS, it's UNOS website, and they're kind of the organ sharing network, and they have a lot of good resources. So the first thing that happens when someone comes in, they get referred to the transplant program, and that can either be by a provider, usually it's their nephrologist, so someone who's helping them with their kidney disease, or they can be self-referred. So one of the first things that happens is that they're screened to make sure that there are no absolute contraindications. Part of my job is I do these screening phone calls, and we talk to them about a variety of things. But for the specific program I work for, this varies from program to program. But the specific contraindications to transplant are if someone is over the age of 72, if their BMI is greater than 38, if they are positive for HIV, if they have cancer that's not outside a safe window, which is determined by each transplant program, if they are current or in the past 6 months nicotine user, or if they have declined to have COVID vaccinations and do not wish to have those at all. So we also ask a lot of other questions to make sure kind of what their health status is. For our program, we also require that patients must identify at least one support person. That's someone who will come to all their visits with them and then be able and willing to stay with them for 4 weeks post-transplant to help care for them. And we want a support person because transplant is complicated. There's a lot of things to learn. There's a lot of medications. And in our specific program, we don't feel that it's going to be successful if people are doing this alone. So I kind of talk to the patients, and then we schedule them either with a nephrologist if they're medically complicated and we think maybe that it needs to be discussed before we move on, or we schedule them for an education session to learn more about transplant. And we meet as a multidisciplinary team once a week to have these discussions. So if someone does come for an evaluation, they meet with a lot of members of the transplant team, as you can see from the appointments with. So there's the nephrologist, so that's a kidney doctor. There's the transplant surgeon. We have a transplant nutritionist, a transplant pharmacist, a transplant social worker, a transplant financial coordinator, and then we also have transplant nurse coordinators, which are generally registered nurses. And each person has their own specialty, and they each give their opinion of whether, or not their opinion, they look at the patient and talk to them about their specific, area of expertise, and then give the group their decision whether they think it's safe to do transplant for this patient, because we always want to do transplants and do more good for the patient than harm. You certainly don't want to give someone a transplant and make their life worse. They also have a lot of lab testing, so it's just kind of routine labs, but also infectious disease labs. We do nicotine screening because of are contraindication for nicotine use. Everyone has to get routine healthcare screening and be up to date on that. Things like mammogram, pap smear, prostate exams, colonoscopies, if it's appropriate for their age and sex. And then other testing like cardiac testing, stress test, echo, EKG, and chest x-ray. Dental exams are important because you have a lot of bacteria in your mouth, and we want people to have healthy oral hygiene so that when they're on immunosuppressants after transplant, they don't get infections. And then we also do something called frailty, which are a variety of different kind of tests and scoring systems that we did not come up with, but we did combine together. And it kind of determines what the patient's overall health is like outside of all the testing we do, to see if they will have a successful, healthy life post-transplant. So if people kind of get through the evaluation process and we don't find anything unexpected, and if nothing comes up, or maybe the patient decides that it's not right for them right now, if everyone on the team determines after this evaluation that they think from what they've seen and what the tests show that this person is a good candidate, then they're put on a wait list. So the wait list is done by our program, but it's the wait list in general for patients is through UNOS, which is the United Network for Organ Sharing. Once a patient's on the wait list, they can be called in at any time for transplant. During part of my tenure at my department I'm in now, I was helping with some of the transplant coordinator roles. So I would get a call from one of the transplant surgeons saying that a patient had come up on the wait list and there was an organ for them, and I would call the patient and help bring them into the hospital and make sure that they were still in good health to have a transplant. So that's for deceased donors when an organ comes up. But once you're on the wait list, you can also get an organ through a living donor. And sorry, I should have prefaced at the beginning of this, at UVM Transplant, we only do kidney transplants, but you could be a transplant nurse practitioner and work at a program that does all sorts of transplants. When a deceased organ becomes available, the UNOS computer system generates a ranked list of candidates who are suitable. The ranking takes a lot of pieces into consideration that I don't dare even try to explain, but it essentially runs a list that the program gets, and you hope that if you're in kind of the top group, it's usually someone that's listed as one of the top 4 that will actually end up getting the organ. And then while people are on the wait list, they need to come to annual appointments and have specific testing done to make sure they continue to be healthy while they await transplant. And then hopefully the patients get called in for a transplant. This is specifically talking about more of a deceased donor transplant. So that means that someone passes and is an organ donor, or their family decides that they would like for the organs to be donated, and then it gets run through the UNOS generated wait list. So the native kidneys are generally not removed during transplant surgery. Sometimes if people have extremely large kidneys because they have something like polycystic kidney disease, they do need to be taken out. But in general, the native kidneys aren't removed, and the donor kidney is placed in the right lower abdomen. So your kidneys are generally more like in the lower back portion of your torso, but we place it in the front and we connect the arteries and the ureter, so what brings the urine from the kidney to the bladder. Because if your old kidneys aren't working, you don't need that anymore for those. So a lot of times I help assist in the transplants and help with the surgery. Patients are given IV medications during surgeries to help avoid rejection. So these are kind of like really strong immunosuppressants. Generally, if the transplant is successful and it was a really good donor kidney, it starts to function immediately or within hours after the transplant. Sometimes some things happen and maybe the kidney was coming from, say, you know, California and it came here. So that's a long time between when it gets taken out of the donor and gets here. And kidneys are put on pumps, which helps see what the flow is and the health of the kidney is like. But it also can sometimes cause strain to the kidney, which can cause a little bit of damage. Or the kidney is just a little bit lazy because maybe it's been on ice and it doesn't really want to wake up right away. So sometimes patients do need dialysis before the kidney will work, and sometimes the transplanted kidney just doesn't work at all. But you know, the hope is that you have a successful kidney transplant and no complications, but that's not exactly the nature of transplant or surgery. So after transplant, patients are usually in the hospital for about 3 to 7 days if there's no complications. And as I alluded to before, a big part of my job is doing education. We have a handbook, a discharge education manual that we give patients, and we start teaching them essentially the day after surgery. And we have their support person come in. We have to teach them all about this new life they have with their new kidney and how to kind of support them to give them the best and most successful outcome. So we talk about things like restrictions, all their new medications. There's a lot of immunosuppressants and kind of infection prophylaxis that patients have to be on at first, and those get reduced over time, but it's pretty intense at the beginning, learning all these new things. You know, if there's food restrictions, we talk about, you know, exercise and cancer risk. And we try to give them all the support that they need so that they can have a successful and healthy life post-transplant. And then patients are continued to be followed in our clinic. They're followed by the surgeon for a little bit of the post-op period, and then they move on to be followed by the transplant nephrologist, essentially for life, because you always want to be checking up on these patients and looking at their labs and monitoring their immunosuppressants. But it's kind of a whole other complicated part of the transplant follow-up. So that's just a general, very broad overview of what transplant is like. And I think I can safely say I'm involved in almost all aspects of that. So it involves a lot of both medical decision-making and also gets to incorporate surgical training and education, which I think education is a big part of what I like about being a nurse practitioner. Oh, sorry, I kind of talked about this in the last slide. So post-transplant, they are always on immunosuppressants for the rest of their life. Usually it's only about 1 to 3, depending on a variety of things. There's a risk of rejection. Sometimes it can be treated, and unfortunately, sometimes people lose their kidney and have to be transplanted again or have to be on dialysis. Kidneys don't necessarily last a lifetime, so sometimes patients have had multiple transplants, especially depending on how young they were when they had to get their first transplant. And like I said before, they're followed by the transplant center for lab work, medications and symptom management, and any psychosocial issues or kind of nutritional issues that may arise. Sorry, I forgot to add another slide.
So now to switch gears a little bit, since Erin was able to give such a nice broad overview, I thought I would kind of give a more specific case example. So this is just one oversimplified case that, is something that I see pretty routinely, and that you can sort of see the role of the nurse practitioner in how you're involved start to finish. So you can go to the next slide. So this is actually, again, an oversimplified version of a case that happened just recently. But my pager went off, green trauma activation, 18-year-old male, ski crash, that's coming from the scene. What these vital signs mean: his heart rate is a little faster than we'd like. His blood pressure is fine. If anything, it's a little bit high. He's breathing pretty fast, 30 respirations a minute. And his oxygen saturation is 94% on 2 liters. Now, that doesn't sound horrifying. Most of us walking around, are 98% on room air. But for an 18-year-old to need 2 liters and to still be in the low 90s, to me, is a little bit concerning. So this is basically the type of information we get in a trauma page. So you don't have a ton of information. So we respond to the trauma page. This patient arrives in the trauma bay. His oxygen saturation has now decreased to 87%, but let's say that all of his other vital signs remain the same. So I just wanted to use this case to sort of just give you a little taste of how the trauma evaluation process works. So the very first thing we do anytime you're evaluating a trauma patient is called the primary survey. And ABC is what we always talk about. So airway, breathing, and circulation. Airway meaning, do they have a patent airway? Can they move air through their airway? B is breathing. Are they breathing? Are they moving air into both of their lungs? And C is circulation, meaning, is their heart pumping blood to parts of their body? Are they bleeding from somewhere, etc.? So on primary survey, when we look at this patient without any other information, we already are a little bit concerned about the breathing part of his story, and maybe the airway part. We don't really know yet. So then once we address those things, we'll talk about the secondary survey. So let's go to the next slide. Okay, so now we get a little more information from the transport team. They say he hit a tree, he struck the tree with the right side of his body, he was wearing a helmet, and he didn't lose consciousness. So now for our primary survey, which is happening while we're getting this information, the patient is speaking. ANO times 3 means that the patient is alert and oriented. So he knows what's going on, he knows who he is, he knows where he is. So if a patient can speak to you, that tells you actually a lot of information all at once. It tells you a lot about their mental status and whether or not you're really concerned about a serious head injury. The fact that he can speak to you tells you that he has a patent airway and that he's moving some air. So you're reassured initially. So then as part of your primary survey, the next thing you do is you're going to listen to this patient's lungs and heart. So I listened to this patient's lung sounds, and he doesn't actually have any breath sounds on the right side. So that is really concerning, right? Combined with the fact that his oxygen saturation is decreasing despite some supplemental oxygen. He also has an elevated heart rate, which can be a lot of things, right? When we're stressed and scared and hurting, that alone can raise our heart rate. It can also be a sign that somebody is bleeding or a million other problems. The big thing is that you're quickly gathering information and deciding what, if any, of that information indicates that this patient could have a life-threatening problem. So to me, not having breath sounds on one side of your body and known trauma to that side of your body is concerning. So let's go to the next slide. So because this patient's relatively stable, let's say we get a chest x-ray in the trauma bay. So this is, again, a big, the big red arrow showing you. But as you can see, this patient has loss of lung markings on the right side of his body, and we'll say some associated rib fractures. So what can happen is when you have rib fractures or trauma to your chest, air or blood can accumulate between of, if you can see the layers of the pleura is what the pleural layers, the lining of the cavity that holds your lung, and then the wrapping over your lung that helps keep your lung inflated. If that space is violated and filled with air or fluid, that causes what you'll hear of like a dropped lung or a collapsed lung, is kind of the verbiage that you hear most commonly. So this patient needs intervention quickly to get this resolved, right? Because presumably with his worsening respiratory status, this could quickly become a big problem. So let's go to the next slide. So the way we do that is either through needle decompression if the patient is acutely unstable, or through chest tube placement. So this picture on the, I guess on the left side of the screen is sort of a quick step-by-step, but chest tube insertion is part of my job. It's something that I do. So this sort of shows you make a skin incision, you bluntly dissect down to the level of the rib, and then you pop into the pleural space. Often you'll get a rush of air or blood, depending on what's going on there. You put your finger in that hole to make sure that you're not sticking into the lung and that you can feel that you're in the right space. And then you insert a tube to drain the air or fluid out of the chest. Let's go to the next slide. So let's say that putting that chest tube in resolved his problem. We're going to get a repeat chest x-ray in a minute, but we'll continue our survey on to the secondary survey. So the secondary survey, once you've kind of made sure that your primary survey, that airway, breathing, and circulation are under control, it's a head to toe exam of the front and back of the patient with all their clothes off, making sure that you're seeing every part of their body. We use an ultrasound to do kind of a rapid exam, or it's called a fast exam. It's the standing for focused assessment in trauma. So looking for fluid, which would most likely be blood in the abdomen. You can also see pneumothorax on ultrasound as well sometimes. We get a pelvic x-ray that doesn't show a fracture. And we find a laceration on this guy's head that we use staples to close. So it just to show you here, stitches, staples, steri strips, wound closure, there's a lot of options. There's a lot of great skin glues out there now, but that's definitely a part of what I do in my day-to-day. So next slide. Okay, so just to follow this guy through, he's admitted to the surgical floor. We don't find any other injuries, let's say, but he's got his chest tube in place. We got a repeat x-ray and his lung was back up. His oxygen requirement has gone down. He's been stable. The next morning or within 48 hours of admission, we do our tertiary survey, which is simply another head to toe exam to make sure that, no bruising's developed, no new injuries have kind of cropped up or been noticed by the patient now that the dust has settled. So physical exam is part of daily rounding and making sure he has bilateral breath sounds, checking on his chest tube, making sure it's working well, consulting with therapies. We get a repeat chest x-ray that we take a look at, adjust his pain medications, make sure that this guy is able to move around and take deep breaths and do all the things he needs to do. Next slide. Okay, so just to kind of, again, quickly condense this case, after his chest tube has been in for 24 hours, we initially put these tubes to suction, but after that 24-hour period, if the chest x-ray doesn't show any reoccurrence of air or, rapidly accumulating fluid or anything like that, then we take the tube off suction and do a trial, what we call a trial of water seal, meaning that the tube is still, nothing can get into the chest through the tube, but it's not actively under, negative pressure. His chest x-ray shows no reoccurrence, so I take his chest tube out at the bedside. We watch him for several hours and send him home. And then in follow-up, he's gonna come back. I'm gonna take the staples out of his head. I'm gonna look at his outpatient chest x-ray and make sure that there's no problems. Sometimes people can have bleeding or things like that occur after they're discharged, and send him on his way, hopefully never to need the trauma service again. So it's a very simplified version, but it sort of shows you kind of the multiple contact points with a patient and all the sorts of things that a trauma NP is doing throughout the day.
Thank you so much. Those were both really interesting cases. And I have a question to follow up with both of them. It sounds like you both get to do really incredible things and save lives, but on the flip side, you're also around for really hard moments, such as when you described a kidney doesn't work or if a trauma case isn't a quick fix. And I wanted to know how you emotionally support yourself and your coworkers through that side of medicine.
That's a very good question. I think maybe one of the reasons it's good to have some experience in healthcare before you decide to commit your life to it is because no matter what role you have in it, you're going to be exposed to both the best and worst of it. And I think seeing how that makes you feel and how you're able to manage that, and support yourself or be supported is important. Working in healthcare, it doesn't matter what role you work in, there's going to be bad outcomes. Your patients are going to pass away. They're going to have, you have relationships with not just the patients, but like their families, support systems. So I think you have to see how that makes you feel. And if it's that it kind of pushes you to just be a better healthcare provider and just makes you know you want to continue doing this to help as many patients as you can. I think that's when you know that you're in the right field. I mean, I'm making it sound easy. Some days there's terrible days, you cry, you go home, you think about patients for far longer, than is probably healthy. But I mean, I think working in a good environment where you have good coworkers and colleagues, but to be honest, I mean, even just someone not in your department, I mean, Maria and we see each other in the hospital. We're on like some committees together. We don't work on the same service, but I certainly feel like as nurse practitioners and as colleagues that, I could reach out to her or any of my other nurse practitioner colleagues if I felt that I needed support that I wasn't necessarily getting from my immediate team, or maybe I just needed, something extra. So I think it's important to have support both at work and outside of work, and know that it's not going to be all consuming and make you feel like it's not worth what you're doing.
Yeah, I think to echo what Erin said, it's certainly not all sunshine and roses, and there are some really horrendous days and some really gut punching days where you can't save somebody or something just goes horribly wrong, because healthcare providers are humans too. And just the simple fact that we care for humans, we are not infallible, and people die and things go wrong, and terrible things happen out in the world that, particularly in trauma or, cases like that sometimes can be really difficult to shake. As a trauma team, we debrief about particularly hard cases. I think what Erin said about having somebody outside your department too can be really important, just because it's a fresh perspective, it's a different lens, it's somebody who can be more objective than people that were maybe involved or knew the patient too. But a lot of it is self-care and self-protection too, making sure that you're spending time with your family and taking care of yourself and knowing that when things feel really hard, that you need to talk to people about it, and you need to, process things and not just stuff it all away, because we all have to deal with things in our own way. But certainly it can be a really huge burden for people.
Wow, thank you so much for sharing that. And it definitely has its ups and downs in healthcare, but it seems like you both are still extremely passionate about what you do, which is just so great to hear. I had a question about, in terms of like the transplant. I guess it could also be relating to trauma too. I know that it is kind of more common practice to, when you're getting a kidney transplant, that you just receive one, like you only need one kidney usually. What are some circumstances, or are there circumstances in which you transplant both to a patient, where you're getting two kidneys from a donor instead of just one, if that happens?
Yes, that can happen. So sometimes a transplant surgeon, or it's mostly the surgeon's decision, but sometimes, they kind of talk to other members of the team before they decide to pursue this. But, maybe if there's someone who is going to have a really hard time getting a kidney because of a variety of issues, they may decide to take, if they're allowed to, take both the kidneys from the donor, because maybe like neither of them is great, but together they might work okay. And so sometimes they would do that. Also, sometimes depending on size, I will preface this that I don't have actual real life experience with it, but sometimes if it's younger persons who are the donors, obviously only in a deceased donor case, but if they have smaller kidneys, and they're going to someone who's like a larger adult. So, you could have someone who, say, was, 12 years old that, something happened to, and their kidneys are going to be donated. But if you're going to put a 12-year-old kidney in a 45-year-old person, that's probably not the best size match, and is probably not gonna give you the best outcomes, because it's just too small for the bigger body. So sometimes they would use both of those, but I would say a lot of the time, especially in a transplant center like I'm at, which is a smaller one, we really, focus on trying to do the best matches, and it's usually just one that we do.
Thank you. And then I have a question to wrap up the session that we love to ask our panelists, and it's, what is your favorite part of working at UVM Medical Center, either with the Vermont community or just the staff at UVM MC?
Well, to speak for myself, it's definitely my team, and living in Burlington. But my team, I work with, I'm the only nurse practitioner actually on the trauma team, but I work with 3 PAs and 8 trauma surgeons. And we have a really wonderful team. We have a lot of fun together. We all bring different skills to the service in a way that really complements, our skill sets complement one another. And, generally speaking, we get along pretty well, which in surgery isn't always the case. So it's a special situation.
Yeah, I think something that's special about working at UVM and working in Vermont is there's more, I guess, a sense of community, because it's you know, a pretty rural population, the whole state. Burlington is obviously more built up, but, you know, I think it is a pretty rural state, and we take care of both Vermonters and then a lot of people right across the lake in that part of New York. So I think you just meet a lot of people from a lot of different backgrounds, and there's just a good sense of community, both because of you kind of have to be in the type of state we're in with, you know, we're the biggest healthcare center in this area. But while you have that rural population and kind of a lot of people who have lived here and grown up here their whole life, you also have people from all over who come to work here because they love living in Vermont, and that gives you a lot in common, or they kind of want to help in a more rural population. So I think it's just a really nice mix of getting to work at, you know, kind of the major hospital for the area, but also have that kind of like more community feeling, and feeling like you're really helping the whole population and all the different types of people who live in the state or like the general area. I think it's nice.
I think that, as you just said, you know, the fact that we're an academic medical center and a level 1 trauma center in a non-urban environment is a super unique situation, which is really, really cool.
Yeah.
Thank you. And we do have just one more question that popped up in the chat, asking about how travel nursing seems to be a job in high demand right now, and if there are opportunities for nurse practitioners to do short-term contracts like there are for RNs.
Yeah, go ahead.
Yeah, there are. It's a little bit different. I'll give you my point of view, and then Maria can obviously let you know what she thinks. So I think being like a travel nurse practitioner is a little bit different. I don't think there's as many opportunities. And to be honest, I think travel nursing is super appealing right now because the pay is outrageously high. And I don't think it's exactly the same like for nurse practitioners. If you're looking at it more to travel and go different places, then you know, it's a good opportunity, but it's definitely not like the pay boom like it is for RNs right now. I also, you have to be licensed in a lot of states usually, and licensing is not always straightforward and easy, and it can be costly and it can take a long time. And personally, I think being a travel nurse practitioner, it would depend on the specialty that you're in, because I think it might be hard to jump in and learn the system and the population and who you're working with for a short period of time and be a good provider just to leave again. And I also think sometimes there's not a lot of support. I think sometimes for traveling NP jobs, they're trying to get someone to fill a huge void, like a huge provider void. And you may have like very little support, or be like the person in charge and only have someone to, you know, consult with over the phone. So, I mean, I think being a travel NP, I'm not sure, maybe if it was like, and Maria can probably talk to this a little bit more, but I think maybe unless it was in like emergency medicine, but even then still, I'm not sure it would be as fulfilling, and it honestly might be very overwhelming. I would not recommend it as a first job.
I do think it's, you know, the little that I do know about it is that it's structured much more like locum tenens positions for physicians. It's not set up in quite the same way as travel RN positions are. But there are certainly opportunities out there, and there are agencies that will help place you and help you figure out licensing and things like that. But as Erin said, I would definitely try to get the lay of the land before you jump into something like that. Because as she said, that often they're trying to fill a very, very big hole with you.
Yeah, if I could just add one more thing, I think I think one of the most important things about being a nurse practitioner and at your first position after you are done with school is, in order to be successful, you need to have good support and work with people who are willing to lift you up and teach you and guide you. I don't think that it's something you should just jump into on your own. You know, you need everyone who works wherever you're going to work, the nurses, the medical assistants, the NPs, the PAs, the doctors, to really be invested in helping you learn and grow so that you can be a good provider. Because I think without that foundation, it is hard to feel confident in your skills as a provider and really grow and learn.
Yeah, I would agree with that completely.
That's very good advice. And I just want to say thank you again to both Erin and Maria for sharing, the joys of being a nurse practitioner. That clearly comes through so well with both of you. And it was really great to hear your stories and what you do in your careers. So thank you again. And thank you for everyone joining us tonight. Next month, we will be featuring a respiratory team with Matt Kinsley and Sarah Wagner, who is actually another NP. So that will be a great session. It'll be on March 17th. So we're looking forward to seeing you all again. And I hope everyone has a great night. Thank you.
Thank you so much
Thank
for
you.
having us.